Thank you, Andrew. I think we can start. Hello, everyone. Thank you so much for joining our SAPA webinar tonight, a bit of another COVID webinar. And tonight we're going to talk a little bit more about numbers, but really about the treatment of COVID. And in our case, in pediatrics, about the treatment for our MIS-C children. So we're going to start with Prof Cheryl Cohen. So we're very fortunate to have her tonight. So she is an associate professor in epidemiology at WITS and also a co-head of the NICD in South Africa. She is a qualified medical doctor and she's also a fellow of the College of Pathology. She works very closely with the South African Department of Health as part of her role in a position at the NICD, and she's really been part of so many surveillance programs for pneumonias and helping with policy making in treating and preventing pneumonias in South Africa. So she's currently part of the several national advisory committees, and we are very grateful to have her to talk to us tonight about what does the numbers in pediatrics mean, how is it looking, where is the outbreaks, and just to generally speak to us about the epidemiology of COVID in children. Thank you so much for joining us.
I'm just going to try and share my screen and then put it into slideshow. And is that good? Can you hear me and see me and everything?
Yes, we can see you and we can hear you.
Great. So thanks very much for that introduction, and thanks for the opportunity to speak to this audience. In fact, my talk is really going to have two parts. So in the first half of my talk, I'm really going to be talking mostly from my position at NICD, and I'm really going to whiz through a quick update from our surveillance, really showing you what's happening in terms of the epidemiology with a focus on kids, and you'll see it's actually really quite interesting, just the trends. And then the second half of my talk, again, I'm just going to give you a quick dive into an intensive burden and transmission study that we've done in South Africa, which really goes under the surface to try and understand the transmission dynamics. And again, I'll just have time to give you a little snapshot of the results of that study, again, with a particular focus on children. So just to start off with the surveillance data, this figure is really what you'll see on our NICD reports, and at the bottom I've given you our website. Every week we release a whole lot of detailed epidemiologic reports on the progression of the SARS-CoV-2 epidemic, and all of the slides I'll show in this first part all are freely downloadable and updated every week on our website. So this is really one of our basic graphs. It really shows the incidence of SARS-CoV-2 cases by week in South Africa and by age group since the start of the epidemic. And you can see a picture that I'm sure everybody in the audience is very familiar with our three big SARS-CoV-2 waves and the trends in the different age groups. And I think the first thing just to highlight, I'm sure this group is aware of, is that COVID is much less common in children. And you can see that the left-hand graph has all ages. And here on this graph, what we've done is we've taken out the adults, so you can see only the kids. And you can see that in general, children have a much lower incidence of SARS-CoV-2. And this black line is the average incidence for South Africa. So in general, kids are tracking way below that incidence for adults. And also you can see that incidence of infection increases with increasing age. So amongst children, the older the child is, the higher the incidence, with teenagers, having the highest incidence closest to adults. So I think that's a very clear trend. But what you can also see is that there actually is a difference. If we look at the rates of cases detected in children, you see that while sort of on the overall, the waves may not look so different, except the first wave was smaller. In kids, you actually see that there's a progressive increase in the rate of cases or the incidence of cases. And in fact, if we look at this as a proportion, there's actually also a proportionate increase in the cases in children in the second wave compared to the first wave, and the third wave compared to the second wave.
Subtype, which has a
Nazreen, perhaps you can mute. Please. I don't know if someone can mute Nazreen. So I think, that's of interest, right? And then I suppose what's really striking, and I'll talk about a little bit later, is that you see here this increase in the third wave, right? So there was this overall increase, but now in recent weeks, we really see that there are notable increases in the incidence of SARS-CoV-2 in children. And very noticeably, it's a completely different trajectory to what we see on a national level in adults. So in adults, on a national level, the cases are coming down. But in kids, we have seen this increase in recent weeks. And if you go into a provincial level, you'll see that that these increases are really in the provinces that are having the SARS-CoV-2 wave. So it's not in Gauteng and in Mpumalanga and Limpopo where the wave has come down. It's in KZN and Western Cape where they're having the waves. Just to mention, in the interest of time, I don't have a graph on it, but part of the reason for the shift in age distribution is an increase in testing. So there have been substantial shifts in the proportion of all tests done in children, so that with each successive wave, proportionally more and more tests are being done in children. And of course, a big part of that is just the increased accessibility and availability of tests. In the third wave, I think the antigen tests were sort of revolutionary and really bringing much more availability. And we know kids have milder illness. So as there's more access, there'll be more testing in mild cases and more testing in kids. So some of this is certainly driven by changes in testing, but there may be other factors. Just to show you some other endpoints, and this is the admissions. So now we're looking at hospitalizations. Otherwise, the graph has the same structure. Again, the left is showing all ages, and on the right, we're showing children. And I really want to highlight for you the difference in the axis on these two graphs. So while you can see on the right, similar to what we've seen in cases, there is an increase in the rate of admissions in children in the third wave compared to the first, and the second wave compared to the first. The overwhelming message on this graph is that hospitalizations are profoundly less uncommon in kids. In fact, they're so uncommon in kids that you can't even see them on the left-hand graph. We have to change the axis totally for the children's admissions to even be observed. So children have a much lower risk of admissions, but yes, there does, similar to the cases, there does appear to be an increase in admissions. And again, some of this is likely driven again by increase in access to testing, because one thing to note, these data are from our DATCOV surveillance, which takes any hospitalization in a person who has a confirmed test. And we know, particularly in children, a lot of those admissions are actually not for COVID. Those kids could be admitted for all sorts of other things, but if they're tested for COVID on admission, and of course the access has increased by the waves, then they will appear on our graph. And part of what goes with that is we see this very high rate in the 0 to 4 years of age, different to the cases. And a lot of that, I think, is just because that age group is more likely to have general hospitalizations. And then because there's a lot of COVID around, they're more likely to have or to be picked up and diagnosed in hospital. And then this is mortality. The numbers really are vanishingly small. You can see the graph is very, very bumpy. So it's showing, again, similar trends for mortality, but this is really, really exceptionally low numbers. So I think the trend is partly driven by testing, but I think there are two other really important factors that may be driving the shift into children, along with increased testing. And the one other really important factor is immunity. So we know that adults, people from about 20 years of age to about 50 years of age were at the highest risk of COVID in the first few waves. And we also know that probably after the third wave, immunity in that age group might be 70% also. So there is an immunity gap in kids, and so that's part of it, is that the cases are shifting to the extremes of age. And there may also, and is likely potentially a contribution of the Delta variant, in that it is more transmissible, and so it overcomes some of that intrinsic resistance that children have to SARS-CoV-2. But just this slide is really just to highlight yet again that while we do see these trends, those are the major area that's affected is cases, right? So, but children still overwhelmingly have much milder disease. On the left, you see admissions, on the right, mortality, just showing the rates by age and the cumulative numbers by age and or rates by age. And you can see here, I mean, almost invisible, the cases in kids. So kids really proportionately, they're not having a lot of severe disease, and they make up a minority of the severe cases. But that's not to say that it's, obviously, we want to prevent disease in that group as much as we can. Just one slide. This slide is really the same data, but linking the data to the school terms. And this you find in our pediatric report, which we release every month or 2 months. And so really what this shows, again, it's the same graph by age group. The yellow line is the adults, and then the different ages and the kids are all the different colors. And where you see the graph being white, that's when the schools were closed, and where it's a color, It's the schools were open, and we have different colors for the different terms. And I just want to highlight firstly the historical data, where you see really that there's no obvious association between the trends in cases. Well, there's two striking things. I think one is that the trends in cases in children generally follow the trends in adults. So the adults go up and then the kids come up afterwards, and you see that in every wave, right? And the second thing is that there's no obvious relationship between closing and opening of schools and the trends in cases. So for example, here in the first wave, we see the schools were open at, by the time they closed the schools, you can see the cases were clearly already, starting to come down. Then you see this long flat bit where even though the schools were open, there really wasn't any change. And then they start to go up. And then remember the second wave, the schools were closed, but it's still, really, was a very big wave. And then it came down again with no relation to opening and closing of schools. And the same here. Now on this wave, the third wave, it's a bit more complex to see. We do see a reduction around the timing of the closing of schools, but really to highlight that an important component of this and what is likely driving these huge reductions in kids is the unrest. So this is that little red box is the weeks of the unrest in KZN and Gauteng. And you can see that these big reductions we saw in kids are at the time of the unrest, probably because testing in kids was proportionately pushed down even more than adults, again, because kids have milder disease. But then you do see these big upswings, after the unrest, and it is simultaneous to the timing of the opening of schools. So I think, some of it may be clusters, certainly related to schools being open. Some of it is the other factors that we've spoken about. But one thing to highlight, which is very reassuring, is that even though we see these increase in numbers in kids, you don't see a corresponding increase in numbers in adults. So this again supports what we've always believed, is that it's much more the disease in adults that is driving the trends in children, rather than the transmission in children that is driving the trends that we see in adults. So that was it, just a very flying journey through some of the surveillance data, and I'm happy to take questions afterwards. So just to acknowledge that the main collaborators, the PHRU and the MRC WITS Adjunct Court Unit that did the field work on the study, as well as the CDC that funded the study. And also participated in the study. And just one slide to show that the first study that I'll be talking about was based on a previous study we did. The first C was based on a previous study called FIRST, which was a study done from 2016 to 2018, aiming to estimate the burden and transmission of flu. And the reason we wanted to look at the burden and transmission of flu was because, in fact, we were interested in this question of to what extent are young children driving flu transmission? Because we were thinking that potentially we could, instead of vaccinating elderly and risk groups for flu, we could rather target young kids to stop flu transmission in our communities. And you can see here, we did in fact find that young kids have an enormous burden of flu, and they are the main drivers of transmission. But you can also see that one of the real unique features of the study is that the study had a very novel design and was able to look at asymptomatic infection and the burden of asymptomatic infection in a community, and how important asymptomatic infection is in transmission. And we all know that kids are less likely to have symptoms. And so essentially, when the SARS-CoV-2 epidemic happened, it was really quickly obvious that this study we done of flu, the kind of questions it was looking at were going to be really important for SARS-CoV-2. And so we took a decision to restart that study we'd done, the first study, in the same communities where we'd done the original study, and sort of replicate the study, but rather looking at COVID instead of looking at flu. So just a little bit about what the study involved. It was a prospective cohort study, and it was done in two sites. The rural site you can see on the map in green, and the urban site you can see there in the Northwest Province in purple. In each community, we randomly selected about 100 households. And if they agreed to participate, we enrolled everybody in the household. And then what we did is we basically, once we'd verified eligibility, we took their baseline data, their age, their sex, their employment, living conditions, HIV status. And then what we did, it was quite simple. We visited everyone in the house twice a week, once between Monday and Wednesday, and once between Thursday and Saturday. And on every visit, we took a mid-turbinate nasal swab, and we tested it on PCR for the presence of SARS-CoV-2. We asked them if they had symptoms and if they'd been to hospital or the clinic. And then every 2 months, in addition, we took a blood for serology. So essentially, with this very, very intensive, frequent, repeated sampling of people, we were able to track the introduction of infections into the community and how they spread in the community. And because we're swabbing people so often, whether or not they have symptoms, we can also look at the asymptomatic disease. So we can really observe the true transmission that's happening in the population. This slide summarizes some of the main results. It's quite busy, but it really gives you a flavor of the data. On the left, you see the rural site, and on the right, you see the urban site. This top graph really just shows the epidemic curve in the site. So it's the percent, the red is the percent of all the swabs on each visit that test positive. And you can see in the rural site, they're quite a remote community. They had a very, very low first wave, a few cases, but not a few cases in the first wave. And then that really big second wave. And then it came down again. And you can see here that these lines are the percentage of people, cumulative percent of people that are positive, either on PCR or serology only, or PCR and serology. And so you can see as there are more and more cases in the community, the percentage positive goes up until 25%. And this is at the end of March. So the data I'm showing you here go up to the end of March. We do have data until the end of August, in fact, but this analysis is till the end of March. And then just to show you at the bottom, this is what we call a mosaic. Each row is a person. The different people in the same house are underneath each other. And then each column is a visit. And we color the block differently according to the results of the swab. So gray means we didn't get a swab. Light pink is a negative swab, and all the red you see, those are PCR positive cases. So you can see here in the first wave, not a lot of cases, but where you do see red, those are all episodes of infection. Where there's two lines next to each other, that's a cluster in a household, one person infected and spreading to others. And the longer the line, the longer the shedding. And then you see here, this is Christmas, these lines. And then after Christmas, this very big second wave, lots of clusters in the community, and then it goes down again. And the same picture in the urban site, there was a biggish first wave. We only started on the downswing, in fact, and then a smaller second wave. And again, the same picture of transmission and clusters in the community. And you can see how this method, you can really beautifully visualize what's actually happening in the community. Just to say also, around Christmas, there was basically a complete replacement in those communities. Before Christmas was the wild type virus, and after Christmas for the second wave was the beta variant of SARS-CoV-2. Because of little time, just some headline results. Firstly, we took really thousands and thousands of swabs and tested them. And with this intensive sampling, we found that at the end of March, about 1/3 of people had at least one infection. But really to highlight a very different prevalence that was on the previous slide in the two communities. So about 25% in the rural site had a lower prevalence, but a much higher prevalence in the urban site. And now, although we haven't released the data after the third wave, it's gone up to about 50% overall in those communities. Really strikingly, already at the end of March, 3 out of 4 houses had already had at least one person in the house with SARS-CoV-2, and that's gone up to over 95% now. The most striking result we had was that of all these infections, only 17% reported any symptoms. This is despite visiting them twice a week and asking them about symptoms. So what we're seeing is a very strong epidemic, lots of cases, but the vast majority of infections are asymptomatic. To highlight, it doesn't mean the disease was mild. So even in those 43 cases that were symptomatic, in fact, 1 died and 6 were hospitalized. So it's not that the disease is more mild, it's that amongst the mild disease, most of it is actually asymptomatic. In other words, not really so easy to identify. And then the transmission in this cohort, 16% of susceptible household contacts acquired infection. So if one person had it, 16% of the other people in the house would get it. And interestingly, that's really similar to other studies in the world, even where the index case was symptomatic. But we did find the beta variant in the second wave 4 times more infectious than the wild type virus. This graph, I think, is really important for this audience. It shows the age distribution of cases, and it really highlights that those middle age groups, 13 to 59, were by far most affected in the first and second waves. And there was this immunity gap in the extremes of age. And we really see, that's why I think we see as the progressive waves, the shift to the extremes of age, because that's where the immunity gap lay, and it's progressively being filled in. Young children were less likely than adults to get infection, and which is really what was on the previous graph. And then the urban site was more likely to have infection. And then if we look at symptoms, the only factor associated with symptoms was age. So while symptoms are uncommon in all ages, we see that young children were more likely to be asymptomatic, except in the less than 5-year age group, where there's a little bit of a bump up. And then in terms of transmission, really interestingly, we didn't see any association between age and transmission. And what we did see as driving transmission was viral load. A low CT value is a high viral load, and variant. So I mentioned the beta variant has 4 times more transmission, and then the urban site. And what was interesting, although age wasn't associated with transmission, we did another analysis aiming to look at that question before of who's driving the epidemics. Are kids getting it from adults, or adults getting it from kids? And in this analysis, we looked at who was more likely to be the index case in an outbreak. In other words, who's more likely to introduce the case into the house? Is it an adult, or is it a child? And you see here that really with quite a strong association, children are much, especially young children, less than 12, are much less likely to introduce SARS-CoV-2 into the house. So they're very uncommonly the index case. So it's the adults who are catching it and then bringing it home to the house, and then the children are infecting, which again is very important, as we think about issues about the schools. It suggests that even if kids are getting it in the schools, they are not the main drivers of the epidemic in the community. Although, of course, on an individual level, infection can go in different directions. This also highlights, and I think the previous graph of the age distribution of cases also showed it, that there is a big disconnect, I think, between the younger kids under 12, where there's clearly a lower incidence and a lower chance of introducing into the house. When you get into the teenagers, they start to behave more like young adults. And we see that also in the surveillance data, especially in the recent wave, where we see the increase in case numbers in teenagers. But remembering, even though teenagers may be more likely to be cases and transmit, they still have much, much milder disease than adults. So just in summary, the third wave has been associated with a shift in disease into more proportionately more cases in children. Teenagers are the most affected by this. The increase is partly driven by testing. It's partly driven by the immunity gap, but it may also be driven by a propensity of Delta to infect kids more because it is more infectious. And so that partial resistance kids may have as a result of the less ACE receptors could just potentially be overcome. And what's difficult is when you look at international data, most international communities have vaccinated their adults. And so they see the same picture, but perhaps for a different reason. And then just to highlight, admissions and deaths much less likely in kids, and often with COVID rather than due to COVID. In terms of the transmission data, again, children less than 13 years, less likely to acquire SARS-CoV-2, less likely to introduce it into the home, less likely to have symptoms. And really the message is young children are not driving SARS-CoV-2, although teenagers may be more similar to young adults. And it's just to really highlight, because I'm passionate about this, it is important to keep the schools open. Even if we see cases in kids, we must try to keep the schools open. The harms in terms of education and nutrition and society are really, really much greater than the burden of severe illness in kids. Just to acknowledge the whole NICD team that produce all of these data, huge team working day and night, including volunteers to generate our reports, and also the FIRST team. And thank you very much.
Thank you so much, Prof Cohen, for that. That's really an amazing overview of all the numbers that we are seeing. So I just want to know if anyone has any questions for you, to please post it in the chat. Hopefully you'll be able to stick around for another bit if any questions comes up, so that's really great. So for those of you that's joining us a little bit late, welcome to our SAPA webinar. We are very lucky to have 3 experts here talking to us tonight. And I am not Mignon McCulloch, I am Martie Wege. Prof McCulloch is actually on a little bit of a break, so we're really happy for her and we wish her a relaxing time. So next, the next speaker that I want to introduce to you doesn't actually need a lot of introduction from the pediatric world. So it's Dr. Despina Demopoulos. She's a pediatric intensivist currently heading the pediatrics team in the PICU at Donald Gordon Medical Center. She is very well known for her transplant care, but also a lot of other interests, including in pediatric sepsis, trauma, burns, and in pediatric pain. She is part of the SAPA EXCO at the moment. She's our secretary, and she's been very involved in policy development in SAPA, and especially in COVID, and the expert opinion in COVID schools and the management of COVID overall has been really extraordinary. And for many pediatricians, she is their speed dial. if they struggle with a critically ill patient or if they struggle with a patient with COVID. So thank you so much, Despina, for joining us tonight and talking to us about how do we actually manage these children that test positive for COVID. I think the adults, they've had 18 months of it and they've got their protocols all set up. And in pediatrics, we don't often see the sicker children. And when they do come in, often doubt ourselves on how we need to manage them. So thank you so much for breaking it down for us tonight, Doc.
Thank you so much, Marty. Thank you for the introduction. I'm quickly going to share my screen. Okay. All good there? Can you see it?
Yes, we can see it. Thank you.
All right. So once again, thank you for asking me to speak. Obviously very passionate about SARPA and also about COVID, and definitely share Prof Cohen's enthusiasm about keeping our children in school. So thank you for your talk, Prof Cohen, and hoping to follow with some management in terms of COVID in children. So as Marty said, our adult colleagues are definitely, they know what they're doing right now. They're even substituting drugs. They are on the ball with COVID. And us in the pediatric world have actually been quite protected for the beginning part. And now we're seeing very many more kids, but fortunately not so many increased hospitalizations or admissions, and definitely not many more kids in ICU in South Africa, which is great. But occasionally we do get the COVIDs, and sometimes the moderate and severe and critical COVID patients, and get phoned quite often. So I think, and Marty herself also gets phoned quite often. I thought we could just run just quickly through the management. So I'll go through a bit of an introduction. I won't spend too much time on epidemiology because Prof Cohen did that. Definition, we'll do a case scenario, the clinical symptoms, and the most important part of the talk will be the management. When can they return to play? And then we'll conclude. What you need to know is that while I was looking around, going through all the evidence in terms of the management, it's quite interesting as to how COVID gets managed differently in different places. So the UK versus the US versus India versus Brazil, more or less the same at the beginning, but then when the kids start getting quite critical, there's different drugs that get given. So it's interesting to see the different protocols across the world. But yes, I've summarized it in what we are doing here in South Africa. So I won't spend too much time on this. Prof Cohen already went through it. And in the reports that the NICD sent out, as she mentioned, very little, and hers is more updated than mine, very little COVID-19 associated deaths. And once again, you can see, fortunately, the admissions in the pediatric world are low, and even more fortunate, the deaths are even lower. So we won't go into that too much, but we'll actually get right down to the case scenario and how to actually manage COVID in these children. So here's a little 14-year-old with a 3-day history of pyrexia, abdominal pain, nausea, and vomiting, but no respiratory symptoms. Had abdominal distension, tender in the guarding in the abdomen and the left upper lobe quadrant, and middle quadrant, and had a bit of sterile pyuria. On bloods, there was a lymphopenia. CRP was quite high, the CRP of 242. Interleukin 6 was very high, and then the D-dimers were high. Just notice a different, so it's nanograms per meter milliliters. So that's quite high for that range, would be normal, would be less than 500. So what was done for this child when he was admitted? So she was admitted, she was put on antibiotics because they were concerned about acute appendicitis. They did an ultrasound, which was normal. They did an initial chest x-ray, which was fine. And they did a SARS-CoV-2 test. The next day, so this is the initial x-ray, which initially on admission was fine. And then 2 days later looked like this. Within 24 hours, she had increasing dyspnea, cough, went on to oxygen, and then eventually onto CPAP. So if you can just to yourself think about how you would manage this, we'll go through the management of COVID and then we can discuss again. So if you had this child in front of you, would you give this child steroids? Would you give her IV immunoglobulin? Would you give her remdesivir, or would you look at another IL-1 receptor antagonist like anakinra? And where would you put this child? So the nitty-gritty is the management of COVID in children. And our Department of Health actually have got something on the website in terms of management of children. They've got two very similar documents. So I want to just mention them and show you what they say and tell you what we are doing and what we're not doing. So the Department of Health does differentiate in terms of mild, moderate, and severe. So it's important to differentiate initially if your patient has mild, moderate, or severe COVID. And then you can look at a couple of things to decide if it's mild, moderate, or severe. Depends on their mental status, feeding, talking, respiratory rate, respiratory signs, and oxygen. But I think for the pediatricians on the talk, I think what's quite important is the actual nitty-gritty is the severity for us, more importantly, in terms of severe and critical. So we will see a lot of mild and maybe moderate COVID in our rooms and sometimes in the pediatric wards. The question is, when we pick up those rare few kids that are severe or critical, and how do you manage them? So the mild, and according to the latest literature, mild to moderate are usually grouped together. So that usually with the mild don't need oxygen, usually can be managed at home, and usually no increase in oxygen requirements. The severe children are children that often have increased requirement of oxygen. So if their baseline, if they are a chronic child on home oxygen, they're needing more oxygen, or they're needing to go up onto non-invasive ventilation or CPAP, and children that are not on oxygen are keep increasing their oxygen requirements. And then critical is sometimes there's a little bit of overlap here, but critical is when you're definitely going on to non-invasive, invasive ventilation, when there's sepsis, multi-organ failure, or rapidly worsening clinical trajectory. So what are the signs and symptoms? And you'll find this everywhere, but in terms of this document, this latest one from the US, they divide the children 0 to 9 years with the most common signs and symptoms, and then children 9 years and above. So fever, cough, shortness of breath, very low. Okay, so a lot of kids will get fever and they'll get a cough, and then they'll just get some of the other symptoms that we'll see with all viral infections. And so you might get myalgia, headaches, nausea and vomiting, a sore throat, some diarrhea. The older kids will have a bit more shortness of breath. So as Professor Cohen mentioned earlier, the older kids, almost like adults, so they will have more shortness of breath, and they can have more loss of smell or taste, and worsening headaches. The important thing, I think, for a pediatrician to know is which children are at risk for severe disease. How do you know which child you're going to watch a little bit more closely? So if it's quite complex medical condition, genetic conditions, things like trisomy 21, certain neurological conditions, metabolic conditions, congenital heart disease, obesity, definitely, diabetes, some chronic pulmonary diseases. Some people feel asthma, but actually the pulmonologists don't feel asthma is a risk for severe disease. But obviously any uncontrolled chronic pulmonary disease, sickle cell disease, and immune suppression. When you actually have the patient in front of you, and I'll go through this a little bit more, what are the biomarkers that'll show you that the disease is more severe? So that would be the inflammatory markers like CRP, PCT, interleukin-6, ferritin, that is either increased on admission or getting worse during admission, hypoxia on admission, and interestingly enough, in children, gastrointestinal symptoms on admission can often be a sign that severe disease will develop. So in children, usually the duration in the younger kids, the 5 to 11-year-olds, is about 5 days, the median duration, and the bigger kids about 7 days. But there's a small percentage of children that can have symptoms for a little bit longer, and a very low percentage of children that can have longer disease, which I'll also discuss later. The one thing that we need to know, and I'm sure you've seen this very many times with our adult colleagues and adult patients, that the respiratory status can change after a week. And our adult colleagues are very nervous about day 7 to day 10. Fortunately, we don't see it so badly in kids, but if you do have a child that you're a bit worried about, you should know that after week 1, there is still a chance that the child can get worse. So how do we manage? The most important thing in children is supportive. So the antipyretics, so bring out your suitcase and do your usual drugs. So that would be the paracetamol, the non-steroidals. But importantly, you have to prevent complications and management of complications. So the WHO have a COVID-19 care pathway, which is a little bit difficult to understand, and I already mentioned what our government has. And this is what our Department of Health has. So mild disease, home treatment, paracetamol, nutrition, make sure you know the danger signs, and then they say de-isolate after 14 days. We know that we now de-isolate after 10 days. And then they speak about moderate and severe disease, and moderate disease would be in hospital on oxygen, empiric antibiotics, and then de-isolate and continue treatments at home. Severe disease would be going into an ICU, empiric antibiotics, arrange transfer to an ICU and intubate, and once again, continue treatment at home when they're de-isolated. So a little bit of more detail. So with mild, as I said, very supportive, paracetamol, non-steroidals. Hydration is very important in these children, so especially in the smaller kids, so less than a year, you've got to make sure that they're feeding or breastfeeding or whatever they're doing, and they're adequately hydrated, just the same way that you would manage any other viral infection in a small child. Make sure that the parents know what the warning signs are. And in this kind of child, you can do a telephonic follow-up if it's mild. Some of the things the patients are presenting with are these COVID toes, and usually you can just keep them warm and apply topical steroids, really nothing to worry about. In terms of management with mild COVID, so it's not really been proven, but some people do feel that they want to use the vitamin Ds and the vitamin Cs and the zinc, so our adult colleagues use those a lot. We know that vitamin D is really great, but you shouldn't exceed the dietary reference intakes. So you've got to know those. And really vitamin C and zinc, there's not much evidence, but I do use it just for the 2 weeks around the management of the mild COVID. If you've got a child that's known to have a chronic condition, but he's got mild COVID, what do you do? So with an asthmatic, you would continue. So you would encourage, obviously, the use of inhaler versus nebulization, but you would encourage them to continue with the chronic medication. Child on antihypertensives, you would continue in the pediatric group. We wouldn't stop any of those because initially at the beginning of the pandemic, they were changing a lot of adults from ACE inhibitors to other drugs. Pediatrics, we're not doing that. And if your child's on immunosuppressive therapy, you need to discuss that with the subspecialist team. So that varies across the groups. So in the transplant world, for instance, in South Africa, we're not actually changing their immune suppression, but in the States, for instance, they are actually decreasing their immune suppression, but they've got quite significant COVID, and a lot of their children are in ICU on ventilators with COVID. So we are not changing the immune suppression. As far as I know, a lot of our rheumatology colleagues are not aren't changing either, but you might find that specific certain subspecialists are changing the immune suppressive therapy. But in general, most people, when the child has got COVID, are continuing with their chronic medication. So the Department of Health on their document, the one part that I say is not all true is the part where they say avoid the following in children with COVID-19 infection. And then they say avoid non-steroidals. We know that's been proven to be wrong. I mean, obviously, you need to make sure that your child is adequately hydrated and feeding. But high flow humidified oxygen is used. CPAP or bilevel is used. So we do use those. So when it comes to moderate to severe, COVID, the important thing is to know when there's clinical deterioration. And this is the part that parents really need to understand, and that our colleagues in the hospital, whoever's working, needs to understand, and our nursing staff needs to understand this. So a child can deteriorate quite quickly. As you saw with our case, they might not have respiratory distress on admission, and within 24 hours, they can develop a difficulty in breathing, cyanosis, decreased feeding, chest pains, signs of shock, and inability. We know in kids it's very important, the inability to drink or keep down any fluids. So in a hospitalized patient, you would offer oxygen and ventilatory support if necessary. Fluid and electrolytes are quite important. If they are requiring to be in an ICU, definitely we would give them empiric antibiotics. A lot of the guidelines are saying once they're in hospital, you can give them empiric antibiotics. With moderate disease, the chance of bacterial co-infection is quite low. But protocols differ. I must say, I usually give them the antibiotics when they're in the ICU. And venous thromboembolism prophylaxis is quite important in certain age groups, and I'll go through that. So the very most important thing that I want to get through to you is when a child is severe, moderate or becoming severe, and is in hospital and you are concerned, you need to really monitor some things very closely. So the one would be the vitals, obviously, so oxygen sats and blood pressure. And then very importantly, you've got to look for a cytokine release syndrome. So you have to be watching the biomarkers, the CRPs, D-dimers, ferritin, LDH, and IL-6. And if you are able to do this in your hospital, try and get it done at least 2 to 3 times a week, every second or third day. As it has been shown, and we've seen that a lot in our adult colleagues, once these start going up quite early, you need to really nip it to the butt, if I could say, because those are the children or those are the patients that are going to deteriorate and most likely get a cytokine release syndrome. So which are the children that you're going to give Clexane to as a prophylaxis? So kids that are at high risk of getting thrombi, so that would be kids that have got CVCs in, congenital heart disease, obesity, they're on oral contraceptives, if there's malignancies, trauma, other risk factors, antiphospholipid syndrome, some inflammatory bowel, and then obviously a whole lot of inherited thrombophilia, nephrotics, pregnancy, hopefully not too many of those, and severe liver disease. So in certain patients, and then often when they're in the ICU, they land up on the Clexane because they're not really moving, and we're very worried about thrombi. Which are the kids that you're going to give the antiviral therapy to? So usually this needs to be discussed case by case. So I don't usually advise anybody to start an antiviral unless it's been decided by a group of people. So when I say a group of people, I mean just not one pediatrician alone. I usually say discuss one pediatrician, possibly with an intensivist, pulmonologist, and then hopefully with a rheumatologist. And I tend to chat to about 2-3 people before I actually put a child onto antiviral therapy. Not saying that it's, I mean, definitely does work, but there are side effects, okay? And it definitely can cause liver or renal dysfunction. So, and sometimes the patients don't need it. So you shouldn't just jump and give it to them. You really need to discuss this with someone and have the evidence to actually be giving it. So it's a case-by-case discussion. The FDA only approves it for children more than 12 years of age who weigh more than 40 kilograms. They do allow emergency use for children more than 3.5 kilos. Okay, and as I said, the one they use is remdesivir, and you do have to have a positive COVID result before they'll actually allow it in the States. So there is a document with a guidance from a panel that sat down together in January 2021 to decide which kids, and I know it's not reflecting properly, but it shows which children you would consider remdesivir first. So that would be severely immunocompromised kids, so primary immune deficiency, stem cell transplants, children on chemotherapy, severe underlying pulmonary disease, so children that are waiting for lung transplant, cardiomyopathy, severe cardiovascular disease, and then kids that are severe or critical, if they're landing up in the ICU, should be considered with the treatment of remdesivir. And as I mentioned before, more than 40 kilos or 3.5 to 40 kilos, and those are the doses. And for severe disease, you can give up to 5 days, but there is a potential that you could cause their hypersensitivity reactions and definitely problems with liver dysfunction. And then we get to steroids. So glucocorticoids should be used on all children that have severe or critical COVID. And really you can decide which one you want to use. So majority will use dexamethasone initially, and then often if we dealing with a multi-inflammatory syndrome, we'll move on to methylpred, but 0.15 milligrams per kilogram daily, and usually IV when they're severe or critical, and you can go from 5 days to 14 days if necessary. So glucocorticoids and tocilizumab was given to children with severe or critical disease, so children that are hospitalized, requiring mechanical ventilation, non-invasive, or invasive, children that are going on to ECMO, and these are the doses of the toci that you would use. Toci is a lovely drug, but unfortunately we're unable to get it now. So it was quite available at the beginning of the pandemic, and now it's difficult to get. So our adult colleagues have started substituting with other drugs, which I will show you. So at the moment, we're not able to use tocilizumab. So a group of wonderful people sat all together at the beginning of the pandemic, so formed a South African Pediatric Critical Care Working Group, and came out with these guidelines. And I'm sure most of you have gotten, and if you don't, we can make them available. I'm not too sure, they might actually even be on our SARPA website, or I'll make sure that they are on our SARPA website. But there are guidelines to actually show you how to manage a child with COVID. But specifically, it's more about the child who's got severe acute respiratory infection. So the severe acute respiratory infection, according to the WHO, is divided into mild, moderate, and severe. So mild would be a child with cough, difficulty in breathing, and fast breathing. Okay. Moderate would be the above, plus SATs less than 92%, signs of severe distress and general danger. Oh, sorry, I missed. Oops. Okay, moderate is in between that. There's the severe, and fast breathing. So the danger signs, you've moved on to severe. And then there's acute, then you obviously with the severe and going on to critical, that's when we get ARDS. So by definition, ARDS, those are the definitions. So mild ARDS is OI less than 4, or what's called an OSI. So that's an oxygen index using SATs when you don't actually have a gas with you. So an OSI, you can actually look at an OSI and you can say an OSI that's less than 7.5 is mild, less than 12.3 is moderate, more than 12.3 is severe. The management of a child with a severe acute respiratory infection with COVID. So initially, obviously, oxygen for everyone if the SATs are less than 92%, and then you can increase to high flow or non-invasive. If your ratios are between 221 to 264, or if you do your PF ratio 200 to 300, so those are ICU parameters that are used to show acute lung injury. Okay, or if you see clinical deterioration, so the SATs are dropping, or you're requiring much more oxygen with your patient. So it's very important that you monitor very closely, and then consider intubation if your ratio is less than, directly if your ratio is less than 221, which just shows significant acute lung injury. So the third tier is showing that you should be intubating if your PF ratio is less than 200, and if your patient's deteriorating on NIV. So if you've got your patient on NIV or high flow and your child's deteriorating, you have to intubate. If a child is on NIV, within 1 or 2 hours, you'll know very quickly if they're not improving. And if there's any deterioration, you need to escalate treatment. As I mentioned, again, consider intubation if there is deterioration. And when we do intubate, it's lung protective ventilation. Hopefully the child will be in an ICU with an intensivist. If that's not the case, you need to make sure that you understand the lung protective ventilation. So target lower SATs, and more than only 88% in severe disease. Keep your FI to less than 60%. Permissive hypercapnia, tidal volumes 5 to 7 mils per kilogram. PEEP 6 to 10. You can go higher if necessary. Limit your plateau pressures and titrate your PEEP. Sometimes we even go 10 to 15, depending. Make sure your patient's adequately sedated. You can prone them. And then if they desaturate, try to not disconnect all the time. So the use of ECMO during COVID, very interesting, and there's a lot in terms of the adults. They've changed some of their guidelines. They've cut off at a lower range, obviously because of resources. But in terms of the pediatric world, we would ECMO a child who's got ARDS with refractory hypoxemia, despite us trying to do adequate lung protection. If a patient's needing increased vasoactive drugs, septic shock, irretractable arrhythmias, PEs, or if there's cardiocirculatory failure due to hyperinflammatory shock, we would not recommend eCPR in pediatric COVID-19 patients. It's risky for the healthcare workers and the outcome is not good. So this slide I really actually like. This is from Up to Date, and it's actually showing what's developing in COVID with children. So with acute COVID, you can have mild. As I said, most of what we are seeing is just mild, but then there are very few that will have severe. Okay, so that's a small minority that can have, as I mentioned, respiratory failure, ARDS. They can have neurological problems, coagulopathy, shock. Okay, and then there's the cytokine storm, and then there's the children that it's going to be spoken about now by Dr. Kate Webb with the MISCs. The children can develop the different kinds of syndromes, okay. But there is a little bit of overlap occasionally, and we are starting to slowly understand the different subphenotypes, and it's constantly evolving. Currently, we have a kid in our ICU that looks, you would say, a straightforward MISC, but also looks like acute COVID with a cytokine storm developing into an MISC with COVID antibodies positive. So it's very difficult to sometimes just the severe COVIDs put them into one group. So it is evolving. This is our adult protocol at Donald Gordon, which is really a great protocol for adults and is being used for a lot of the older children at Donald Gordon. And in the adult ambulatory management protocol, they would test anybody who's got risk factors between days 6 to 10. Okay, and depending on those results, they would consider actually steroids at this time, and then they would repeat at day 10. And they put them on vitamins, as I mentioned. And then they've got their inpatient protocol where they look at CRP, IL-6 and oxygen requirements, give them the Solumedrol, and then decide in terms of escalating on, depending on those biomarkers in terms of further immunosuppression. This is Professor Guy Richards' Gauteng ICU group protocol, and he's updated it now in July 2021 because TOS is not available. So these are the other options that they're using. Okay, so interestingly enough, the adults are also looking at CRP, D dimers, IL-6s. Obviously, they look at Apaches, increasing oxygen requirements, and then decide if the patient is deteriorating, give them the high dose of methylpred, and then move on to some other form of immune suppression. So besides actually managing the child at the time, it's important to look at the follow-up. Okay, so in the interest of time, I'm going to go a little bit faster. But if a child, who should you be following up? So if it's a child with a mild disease, it's a telephonic follow-up is fine. But if it's a child with moderate disease, so they've had more than 4 days of fever, more than 1 week of myalgia, chills, or lethargy, or if they've had severe disease in an ICU or intubation, if they've had MISC, they are at a higher risk of cardiovascular disease, and you need to see this child when they're de-isolated for follow-up. At follow-up, need to make sure that there's no ongoing symptoms, make sure the cardiorespiratory symptoms are gone, ask for other things like, for instance, loss of smell or feeding. In the younger children might be difficult, but they might be off their food. Neurodevelopmental symptoms. Behavior and mental is a big thing. Need to guide them on how to return to the activity. Hopefully we'll be getting this soon. Catch up routine immunizations, enforcing to continue prevention of infection, re-evaluating for any symptoms and healthy habits. Long COVID has been seen obviously in adults, and the UK, they've actually showed that there are a group of kids that are also developing long COVID. So 14.5% of 12 to 16-year-olds are still experiencing symptoms 5 weeks after infection. So in the interest of time, I'm not going to go into how you specifically would manage long COVID, but if you go and have a look at the American Academy of Pediatrics, they've actually got really nice documents on how to manage the different symptoms of long COVID. So if you do, and it doesn't actually depend on the severity of the child, it just depends on how long they're having symptoms after the infection. You might be dealing with long COVID. When do we return to play? So sometimes you might have very sporty kids or competitive kids that are in your practice. So there are actual guidelines on when children can return. From sports medicine, they actually have different stages that you can look at depending on your heart rate. Okay, but very simply put, if a patient has had moderate COVID, then you do need to do a full physical, which includes an ECG, and they can start returning to gradual exercise 10 days later, but there needs to be a minimum of 10 days that they've been on antipyretics. But if they've had severe critical or MISC, it's 3 to 6 months no exercise and need to get the clearance from a cardiologist. So the second last slide, this is just a summary of everything. Mild COVID, stay at home. You can use paracetamol, saline drops, vitamins if you want. But if the fever is carrying on for more than 4 days, please investigate. It might not be COVID, it might be something else, okay? And then know when the red flags are there and when the parents need to bring their kids in. Moderate and going on to severe, you might, if they're requiring oxygen, you need to admit to the ward. At this stage, I would still, some places are not doing bloods, but I feel, and a lot of the pediatricians and intensivists dealing with COVID feel that once you're in the ward on oxygen, you should have all these bloods done because the chance of deteriorating is high. And then I would monitor oxygen and IV steroids. Severe or critical needs to be in an ICU on high care. I would extend the bloods to include a lot of the cardiacs, the gases, and now we most likely are going to deal with some sepsis there. So I would include PCT, an echo, and obviously an ECG, chest X-ray, whatever form of ventilation or support is required. And at this stage, I would definitely use IV DEXA, antibiotics for sure, Clexane for sure, and then possibly remdesivir or another form of immune suppression. So to conclude, most children will remain asymptomatic, and thank goodness most children will recover. You need to manage according to the severity of the disease. So steroids and antiviral therapy to be considered only in moderate to severe disease. Phone a friend if necessary anytime, and follow up appropriately. Thank you very much.
Thank you so much for that, Despina. I see a lot of very interesting questions in the chat about timing of steroids and what antivirals suggested. So unfortunately, we're running a little bit behind on time. So I'm going to first go to Kate and then we'll leave the questions for the end, but I see there are some discussions in the chat already. So Dr. Kate Webb is a qualified pediatrician and a pediatric rheumatologist. She is a fantastic researcher, and she's done some fantastic work on the immune system and lupus in children, and also completed her PhD. And she was really one of the first responders when this wave started happening with MIS-C. And she recruited multiple people from Africa, and she basically collaborated, and she also present some of her work to the WHO. So it's really, she's a big advocate for children, and she really tried to present pediatric rheumatology in Africa to the world. And she's a really fantastic resource to have on your phone. So she's really helped me out with some of our children. So we're very grateful to Kate talking to us about MIS-C in children. And I'm going to head straight over to you. So thank you so much, Kate.
Thank you very much, Marty, for that kind introduction. Thank you all for having me here today among these great speakers. And I'd like to speak to you about some of the cases with MIS-C that we've been having in Cape Town, as well as some of the response to MIS-C that we've been having across the country. So I'm sure many of you have had to manage one of these patients at some stage in the last 18 months. So it'd be great to have to share some of your experience afterwards. So as everybody here knows, the WHO released this case definition of MIS-C, or PIMS-TS as it was called in the UK. The first cases started to be seen last year in April in the UK with a report of 15 young boys who developed this. And quickly cases were reported from throughout the world. And we actually reported our first 25 cases in the Western Cape in August of 2020. So the WHO and the CDC and the Royal College of Child Health Practitioners and Physicians all released separate criteria and gave the disease separate names. But we've kind of settled on the WHO definition that talks about children and adolescents 0 to 19 years of age, even though we know this can affect much older children. And they've made a pretty arbitrary cutoff of a fever of 3 days. They've grouped the rash, the conjunctivitis, and the mucocutaneous features as one criterion: hypotension or shock, any features of cardiac dysfunction, evidence of coagulopathy, and acute gastrointestinal problems, which can include diarrhea, vomiting, or the severe abdominal pain that these children can present with. They have to have evidence of inflammation and no obvious other cause. So it's a diagnosis of exclusion, but this shouldn't stop treatment in certain cases. And they've required evidence of COVID-19. So I think, as we all knew earlier in the pandemic, it was tough for us to get hold of serology at that stage. So what the WHO did was very usefully put likely contact with patients with COVID-19. So in our context, we related that back to being temporarily related to a wave of COVID in the region, which allowed us to diagnose more of these cases and subsequently confirm on serology. So the US has been some of the first to look at an incidence and have estimated an incidence of 2.1 per 100,000. But obviously these are really rough data. The dots represent cases of MIS-C per 100,000 children, and the shading of the states represents COVID-19 cases per 1,000 children. And as you can see, they're not really congruent, and it's probably because in areas on the East Coast that had high levels of MIS-C, as Cheryl was saying earlier, in the earlier portions of the wave, relatively fewer children were tested. So we probably don't reflect how many children actually developed COVID in these areas or were infected with SARS-CoV-2 and subsequently developed MIS-C. So these data show an incidence per 100,000 children, and this obviously relates back to how many children get infected in the first instance, which we're not sure yet how likely you are once you get infected as a child with SARS-CoV-2, whether you're asymptomatic or not, how likely you are to develop MIS-C. In September of last year, MIS-C became notifiable in the country and is on the NICD Notifiable Medical Conditions webpage at the bottom here. But the uptake hasn't been great across the country. I think that a lot of cases by September had happened and people haven't retrospectively notified these, which is understandable. In the Western Cape, we haven't retrospectively notified as well as we should have. And particularly there's a CRF, which is quite labor intensive, that has had quite a poor uptake. So we're trying to figure out how to do this a little bit better so that we can better describe these patients across the country. And in February, we met with a working group that anecdotally described some of the cases at some of the big hospitals throughout the country. And at that stage, we very roughly estimated at least 173 cases at these hospitals alone. So we're waiting to perform this again after the third wave hopefully decreases, and we'll be able to give a guesstimate about how many we have in the country. At the Red Cross, we were very lucky because we were able to very quickly pivot some of the research that was being done so that we had the ethics and the infrastructure to start recruiting these patients. And because of the proximity to Tygerberg and a good working relationship with Dee and Helena in Tygerberg, we were able to document all of the cases from the very first case in the city. So you can see here, these are the first 69 cases until the end of March in 2021. So from the first case in May to the last case at the end of March, and we're hoping to also add on the rest of our cases that we've been seeing subsequently. And as you can see, there are two distinct waves, which generally follow about 4 weeks after the peak of SARS-CoV-2 cases in the city. There's a kind of equivalent wave-like structure, but as you can see, there's fewer cases in the second wave than there were in the first wave, which is different to how the pandemic of infections looked in the city. So we're really interested to see how our data looks in the third wave, to see if perhaps this is variant related, or perhaps we just underestimated how many children were infected in the first wave. We're really not sure why we see that, and I'd be interested to hear people's opinions. In Cape Town, out of these 69 patients with MIS-C, we had a median age of 7, and we were really lucky to be able to recruit 23 patients who were suspected of having MIS-C. So these are kids presenting to the emergency room with fevers, rashes, things that put MIS-C on their differential diagnosis list, and ended up with other conditions such as TB, typhoid, dysentery, appendicitis was a common misdiagnosis, or a differential viral and skin infections. And these have given us a really nice cohort to compare to. As you can see, as compared to data across the world, children with MIS-C tend to be older than children with Kawasaki. And we were also able to recruit 96 children who were presenting for surgery, for elective surgery at the hospital once elective surgery started up again, which gave us a nice cohort of healthy children to compare to. Similar to overseas data, children of Black African origin were disproportionately affected, we think, as compared to the inflammatory controls and the healthy children presenting to the hospital in the region. So we were able to look at the seroprevalence of the first 96 children in conjunction with Elizabeth Main at the NICD, who did these antibody assays for us. And we don't have enough data here to look at any kind of dynamics or patterns, but so far about a third of these children from the first ones that we started recruiting in August have had detectable antibodies to SARS-CoV-2 in the region. There are periods when elective surgeries don't happen, for example, during lockdowns or during December. So we're continuing to gather these very valuable data. But what these do is they give us children who've been exposed to SARS-CoV-2 but haven't developed MIS-C, which is a super valuable cohort. So as you all know, MIS-C has the typical mucositis that can look a bit like a Kawasaki mucositis, the BCG reactivation. They can peel like patients with Kawasaki do. They can be extremely tender and have peripheral edema as well as arthritis, and quite a profound conjunctivitis often. The rash is polymorphic. It really is different in most children. And I think that these patients were quite severe early on, and it can change quite quickly. So the rash is quite non-specific, I think, in terms of MIS-C. Out of the 69 patients, more than half of them had no one in the household who had been unwell in the last month. Some 17% had a suspected contact, so that's sort of like an uncle who's been a bit unwell. And only 22% had someone that they knew within the household who had COVID. And 14% tested PCR positive, with 91% having antibodies. The most common symptoms in our cohort were fever, as one would expect, as an entry criteria. Tachycardia, rash, and conjunctivitis. And when we did a logistic regression of all of these factors accounting for each other, what we saw was that conjunctivitis, tachycardia, and rash all independently associated with the better odds of being MIS-C as compared to another condition, another inflammatory control. Abdominal pain was also quite common, as well as hypotension. About a quarter had renal disease, CNS disease, lung disease, and 16% had macrophage activation syndrome. And a good proportion of these patients had pericardial effusions, about 6% had coronary artery aneurysms, and about a third had mitral regurgitation. The ejection fraction was significantly lower in patients with MIS-C as it was in inflammatory controls, but not compared to Kawasaki, but we've got far fewer patients with quite a low minimum ejection fraction in some of the patients. So it can be profoundly low in the area of 27, but the average was about 52. And we found a significant difference, not in CRP, when we looked at the comparison between children who ended up having a different diagnosis, but in a slightly lower hemoglobin, quite a profoundly lower platelets, so with a mean of 187 versus 340, quite a profoundly lower sodium, as people will know from treating these patients, and obviously a much higher pro-BNP and TROP-T in patients with MIS-C. And in the beginning, we didn't really know what the BNP would look like in a shock gastro. We hadn't tested that routinely, but now we know from these data that it is profoundly higher in MIS-C. So I just want to show some of the data that we've been gathering so far. The people at the South African TB Vaccine Initiative very helpfully performed for us the expression of 84 immune genes. And what you see here, this middle box, is patients with MIS-C, and during the time period, that's over their samples. So that's the initial gene signature of MIS-C, which improves with time. And these are healthy patients here, and you can see how very different the MIS-C is to this block that contains healthy patients, if you just look at the general pattern. But as MIS-C tends to get better, they do start to look like the healthy patients, if you have a look over there. And this shows that as well. So when we cluster all of these data together to give us patterns, we see that patients MIS-C who haven't had any treatment, these are MIS-C who have had IVIG and Medrol and just IVIG in the yellow, but with treatment in red, the pre-treatment patients eventually become this black circle here. So these are MIS-C on follow-up, which overlaps with healthy children, showing that there's a complete resolution, but quite a distinction in gene expression in MIS-C. We had a look with Tandeka Moyogwete and Penny at the NICD as well, Penny Moore, to have a look at the antibodies. And it seems like children who had SARS-CoV-2 and didn't develop MIS-C tended not to have any difference in the amount of antibodies as compared to children who did develop MIS-C, which was quite surprising. They didn't seem to make any more antibodies either to spike or nucleocapsid. But there was a trend for patients with MIS-C to have antibodies that were better able to neutralize SARS-CoV-2. And equally, they were better able to induce phagocytosis than children who had had the infection not developed MIS-C. So these are data that we're still working on. The UK has released a consensus statement on MIS-C. And as you know, the treatment for MIS-C is based loosely on the treatment for Kawasaki disease because of the clinical similarities in phenotype. And the US has also released treatment guidelines, the American College of Rheumatology. So the first thing that they've recommended, that I think the majority of us use, is IV immunoglobulin at 2 grams per kilogram using an ideal body weight. So these are well-nourished children, and they're often older children. So these can be really big volumes of IVIG that we're giving. So we do tailor that based on the cardiac function and occasionally hyperconcentrate that or give it over a longer time period. There's very few data, as I'll show later, which argues for any of these arms being superior to the other. They use a second-line therapy of IV methylprednisolone at 10 to 30 milligrams per kilogram per day for 3 days. So those are really big kind of rheumatology, nephrology doses. The Americans recommend either using these doses or using a smaller dose of 2 milligrams per kilogram. The UK recommends a second IVIG if you failed both first and second line. But in children who are at higher risk of coronary artery aneurysms, if they had Kawasaki disease, they recommend that for those less than 12 months or with coronary changes to use IVIG and methylprednisolone at the onset. And having failed both 2 courses of IVIG and second line IV methylprednisolone, they recommend biologic therapy. And in the UK, they recommend a choice of anakinra, an IL-1 antagonist, or tocilizumab, which is an IL-6 antagonist. We've had a bit of experience with tocilizumab, which luckily we still do have available in Cape Town. But I think that there's really no data about which is better. So only this year have some retrospective studies started to come out looking at any benefit of one drug versus no drugs versus a combination of drugs. I think that in a disease like this, where these children are profoundly unwell, obviously everyone tries treatment in the beginning. So it is a hard disease to research about what works better than anything else. And I think that it is hard to design a prospective study, and I'll speak about that in a little bit. But the first people to look at retrospective data were the French, who released this study looking at all patients who had presented in France. What they did was they propensity matched. So they had 34 patients who had received IVIG and methylprednisolone and 72 who had received IVIG alone, and they matched them for severity. So obviously the kids who are more severe are more likely to get both drugs at the beginning. So they took those patients out who matched similarly severe patients with IVIG alone. So that was 9% of the children, and they looked at who failed. So who got a fever after 2 days, or who had a recurrence of their fever within 7 days. And what they've reported from these data is that receiving both drugs, IVIG and methylprednisolone in the first instance, protects you against having a recurrence of fever. Then the NEJM in June of this year published 2 papers, one from the US and one from the UK, similarly looking at retrospective cases and trying to look for any treatment effect and any benefit of one treatment over the other. They matched 103 participants who had received both IVIG and glucocorticoids versus 103 similar participants who had only received IVIG. And their primary outcome was cardiovascular dysfunction. So they made a composite score of left ventricular dysfunction or shock as their primary outcome. And what they found was a protective effect of IVIG plus glucocorticoids in this relatively small number. When they analyzed those 2 outcomes on their own, they didn't see the same protective effect. And when they matched these patients slightly differently, there were some differences in the outcome. So the BAT study was the best available treatment study, also published in the NEJM in June. And this was a UK-led study that recruited from 32 countries around the world. People entered data about their patients into an online platform. And what was quite nice about this study is that it was multi-centered, but also that there were arms where they only used steroids because IVIG was not available. They also looked at whether a child needed respiratory support by day 2. They didn't look at a kind of fever or a febrile response or an inflammatory response, but they found different findings to the US or the French study, showing that they couldn't find any benefit of using IVIG plus glucocorticoids versus IVIG alone. And similarly, when they looked at the effect of just using steroids versus just using IVIG, they couldn't find a benefit either way. And these were higher numbers, so 100 patients who they only used glucocorticoids on, and 250 who they'd used IVIG alone on. So I think the real point of the story is that we just don't know yet. We think that perhaps there might be some benefit in using both drugs, but we really just don't know yet if that's the best thing to do. In our cohort, 65 out of 69 received IVIG, 64% of patients received steroids, 42% received both, 33% received only IVIG, and only 2 out of 69 patients only got methylprednisolone. Quite a lot of 6% of our early cases received tocilizumab. And you can see here, once these patients get better, their CRPs tend to come right down. I put this as day since IVIG, but I don't want any correlation with treatment here. I don't know if it's the IVIG that's doing it. I suspect it is. It's one of the treatments that we're using, but these aren't blinded data, aren't randomized data. So going on to that, as you all know, the recovery trial is a large platform trial run out of the UK, and they've recently added an arm for pediatric PIMS or MISC. And we are developing our own arm of this trial, an independent sister arm, where we hope to pool data with the UK, with Switzerland, and with centers in South America. And we've just put this into ethics, and we're about to put it into the second round of SAPRA. And we want to randomize, stratified by severity, into children who could receive IV methylprednisolone, IVIG, or supportive care if they are not requiring ICU. And what's nice about this trial is it's meant to mirror real life. It's meant to mirror real decision making. So clinicians can go along a pathway, and if they feel supportive care is unsuitable, that arm can be not available to that patient. If they feel the patient is quite a Kawasaki phenotype, they can say that IV methylprednisolone is not suitable in the first instance and go for IVIG. And there's no rules around this trial. There's the first randomization and the rest gets analyzed. So if a doctor is uncomfortable with the first treatment or there's deterioration, they can always change the drugs. And we've included up to 2 milligrams per kilogram of oral prednisolone in the supportive care arm. So we hope to really roll that out quite quickly and hope that other centers come on board so that we can participate and gather some of these data, because I think it's quite important for us to understand these treatments that we're using a bit better. So just to show, we've admitted almost 40% of these patients to ICU. Almost 40% have required inotropes and oxygen, and we've ventilated 10% of these patients. And the duration is variable. We've got a median duration of stay of about 7 days, but it changes in each wave. And there's always the very unwell patient who stays a little bit longer. So we have a really nice cohort of MISC in the country, and we've got good samples to match, and we've got great collaborators who've been helping us analyze these data. We've got some early signals that the antibodies may be different, and we've got some nice gene expression data. But what we really hope to do is join larger trials to look at RNA sequencing, to look at T-cell responses, and we're performing whole genome sequencing with the support of the SAMRC on the first 40 of these patients as compared to healthy children. And we'd like to develop a risk profile for these kids and perhaps set up the local arm of the recovery trial. We also want to start recruiting children who've been vaccinated and using this platform to learn as much as we can about the immune response in children with vaccination as soon as that begins. And just a very brief word on vaccination. We've always wondered if MISC is antibody mediated. Is there a possibility that vaccination could induce MISC? There have been reports of a myocarditis in patients who are younger who have been vaccinated. Typically, this is after the second mRNA vaccine, and it's typically more common in males and adolescents. And these are very rare reports among millions of vaccines. The CDC is electing to continue vaccinating children older than 12, and the UK is being a bit more cautious. But this is something that we're going to have to keep an eye on and really answer this question, because we have such a relatively high proportion of children in our population that vaccinating young people is going to be something that we're going to need to do for adequate coverage. So I'd just like to thank everyone who's helped in this study, and I'd be very happy to take questions. Thank you.
Thank you so much, Kate, for that fantastic overview. So I'm going to jump right into questions. We've got about 5 minutes for questions. And the first one I want to direct towards, let me just open these chats again. Sorry. So I want to direct it towards Prof Cohen and just ask Ziad's question. I'm actually quite interested in, where he asked about what is your hypothesis, what's going to happen to the numbers in children going forward. Do you think we're going to rely on this immunity gap that there is, or do you think we're going to see less COVID or more COVID in children going forward?
So thanks, you're not Mignon, you're proposing as Mignon, but thanks for that question. The reason I answered all the other questions in the chat, and the reason I didn't ask Ziad's question is because I used to predict and answer questions about what will happen. And one thing I can tell you incontrovertibly is that I'm never right. That being said, I mean, my opinion, which is probably wrong, is that, the immunity gap, there's much more immunity in adults. We don't have, I haven't looked in depth at our seroprevalence data after the third wave, but it's probably 60 to 70% in adults, right? So we will continue to see with successive waves proportionately more cases in kids. I mean, it is likely. Now, whether what that means over time, I'm not clear. Once we also know that with the new variants like Delta, it's not really possible for us to exceed herd immunity. In other words, for COVID to ever stop circulating in our communities. However, when lots of people get immune through vaccination or infection, the overall case numbers will be expected to come down. And when they come down, they'll also come down in kids. So I think the overall trajectory we would expect is that eventually, COVID cases will come down, and it will come down in kids as well. But there may be this proportionate shift to more children, may go on a little while, but overall, hopefully all the cases will come down. And then if we get enough vaccination out there or herd or immunity in people, it won't disappear, but it should become more like flu. And then I think that's the big question. When it becomes a seasonal disease, will it then change its age distribution, as happened in the flu pandemic, and affect kids more? But I think that's sort of unknowable for now.
Okay, great. Thank you so much for that. So then I'm going to quickly ask Despina for, I think everyone has asked a couple of people have asked, what is the benefit of IL-6 versus doing a CRP? And I think there was a lot of debate and answering of questions in the chats, but I don't know if Despina, you can maybe just give your opinion about that.
Yeah, thanks. I made you Kate, sorry. Minion, Marty, Kate, okay. All the Cape Town people. Well, you're not Cape Town anymore. So yes, so what's happening is in private a lot, they're using the IL-6. They're doing IL-6 and CRP, but IL-6, as my colleague Dave also mentioned, it just rises before the CRP does. So basically, it tells you a day or two that before the CRP does, that your patient's going to have quite an inflammatory response. So what's been happening and especially the adult colleagues at Donald Gordon and Guy Richards and the group, is they've been doing both. And as soon as they're doing it on day 6 and then they're doing it on day 10, and they're seeing that, or if the patient deteriorates, and they're seeing that the IL-6 will go up before the CRP. And so as soon as the IL-6 goes up, they actually start with the steroids then. And they feel that they've prevented a lot of patients from landing on oxygen or getting into hospital. So I think it's difficult to get IL-6 in the state, and also it takes a bit of time to get the results. So I think if you're going to be working in a place where it'll take 2 days to get the IL-6, I think it's pointless. But if you are able to, I mean, we found that it's made quite a difference, and we have been doing it on our PEDS patients. And it's really amazing. And it also helps in terms of the whole cytokine storm. So a lot of the questions in the group are also mentioning, so I don't know if it's between myself and Kate, the whole spectrum of acute COVID versus MISC. And I think sometimes it's very difficult to distinguish. I see Shivani's also said that. And sometimes fever is not enough, and sometimes there's overlap, and there's all a different kind of evolving presentations. So as I mentioned in the chat, it's always supportive management, and then clinical, obviously, and then if there are biomarkers that you're able to do, I've used those a lot of the time to distinguish. And so if it's MISC, obviously we do many more bloods, so we'll do the whole pro-BNB and the ferritin and all of that. But we do ferritin also in the acute phase as well. So we found that IL-6, LDH, acute ferritin, CRP, all of those help us know if our patient's getting worse. So basically doing it every second day, or some of them every day, and then starting steroids and escalating faster, for the child that's going to get worse.
Thank you so much, Despina. I see Dave's hand is up, so I don't know if he can share some of his wisdom and what he's learned.
No, thank you so much for the opportunity and for these great talks. No, it wasn't a wisdom, it's a question. And it's to Despina and Kate, and I'm just finding that this is from the cardiology side of things, that there's so many patients being referred for cardiac echoes under a MIS-C banner, and when we've been going through the criteria, they certainly haven't met our case definitions, regardless of whether we're just following the WHO between all three of them in actual fact. And obviously I don't want us to not refer children so that we miss, because we knew in the evolution of the disease. But what I'm wondering is what is our general feeling as pediatricians seeing these kids and just kind of almost just labeling them as MIS-C? And if we're doing that, then perhaps we might be adding on therapies that we shouldn't be if they're not meeting what we're using as these definitive criteria, or are the definitive criteria not inclusive enough? I'm just, that's sort of where I'm really stuck at the moment, because we're getting a lot of referrals of these query MIS-C patients, and almost saying that we as cardiologists must find the cardiac problem. And I'm not talking about the hypotensive classic patients. Those are easy. We must find the coronary abnormalities to then confirm the label of MIS-C, which is the wrong way around.
Dave, I totally agree. Sorry, Kate, can I just 1 second? You're welcome to. And we've just had a case like that where the echo was actually normal, and we thought everything fits into the whole MIC, conjunctivitis, membranes, the whole thing. And actually, I think it's just an acute with a huge cytokine storm. And the problem is polygam, the kid has stroked, kid had kidney dysfunction, you know what I mean? So yeah, the polygams and some of the steroids are not without any, any problems. So
yeah, I mean, I agree. I think that MIS-C does have a spectrum. You know, there are the less severe and the more severe, but by definition, it's a multi-system severe disease. And I mean, I think that we haven't struggled to diagnose the ones we've got. I think MIS-C it needs to be on your list, but when it's there, you know it's there, kind of thing. And it's quite a unique disease that is quite easy to spot and quite obvious. Especially with the abdominal pain, I think is one of the big things, and the conjunctivitis and the tachycardia. Having said that, you know, some patients with MIS-C can turn very quickly, but usually they have a conjunctivitis or a rash or something that looks quite specific. I recently had a patient who had a BNP of 40, and then the next day had a BNP of 24,000. So clinically, they do have shock and tachycardia, and they can turn quickly. One normal echo doesn't rule it out, or a normal heart, but I think that clinically you can definitely diagnose MIS-C, and people are worried about missing it, which I think is good. People must know about it, but you'll know if you have it. You know, I don't think it's a subtle presentation. By definition, these children are quite unwell.
Great. Thank you so much, Kate and Despina, for that. I think, unfortunately, we've come to the end of our time, and some very interesting discussions in the chats. And thank you so much for some of the presenters answering that, and some of our other colleagues trying to answer that. The presentation will be available on YouTube if you want to go and recap some of this. Just a little bit of advertisement. So the critical care document is also available on our website, so the South African Pediatric Association website. And I really want to urge you to become a member. So if you're a member and you joined us tonight for the webinar, you have scored a CPD point. So you can await your certificates. And yeah, for next month, we are going to have a webinar on neurology. So we're going to look at the update on status epilepticus, and also on the floppy infant. So please join us again next month. It's the 29th of September, same time, same place. We will send out the links. And thank you so much again to our presenters. It's been fantastic. And you can just see the interest and how thankful people are by commenting on the great presentation. So thank you, everyone, and stay safe, and good luck with this third wave and all the misses that it's bringing us. Thank you so much.
Good night.